All right, so this video is going to be discussing the NP's role in the patient with heart failure, which is a big one because heart failure is a chronic disease. It's a disorder where the heart has inability to pump. So it can be caused by coronary artery disease, systolic hypertension, chronic hypertension, and other heart disorders. And then on physical exam, you're going to see the patient being short of breath, dyspneic, fatigued. You're going to hear sounds like rhonchi, rales, hear edema and liquid in the patient's heart, and then also peripheral edema. You might note some JVD, but that probably is not going to be a test you're going to do outpatient regularly. And then there are really two types of heart failure, which we'll talk about really briefly. So right-sided heart failure and then left-sided heart failure. So left-sided heart failure, you have the patients that are cyanotic, tachypnic, a lot of sputum, cough, crackles, wheezes, and pulselessness, confusion, tachycardia, fatigue. So basically, the body is not getting the blood that the heart's sending out because the heart is not functioning, well any longer. And then you have the right-sided heart failure, which is cor pulmonale, which typically happens as a result of left-sided heart failure. And this is when the heart can't pump the blood out, so the blood ends up just pooling, and it is kind of cyclic. So some of the symptoms have a little bit of overlap, but you're going to see the weight gain, the ascites in the GI, anorexia other than the ascites, dependent edema. You're going to see the JVD, fatigue, and then enlarged liver and spleen, because the blood is pooling in the rest of the body and isn't being returned to the heart. So when you're thinking about it like that, let's now consider what kind of medications you're going to use for heart failure. So you're, first of all, never going to use a calcium channel blocker in heart failure. This is because the heart is already having a lot of issues beating, and calcium channel blockers actually stop beats. Specifically, they stop atopic beats, so beats that are not helpful to the heart and might be asynchronous in terms of the heart's electric conduction, but you want every beat you can get with heart failure because the heart's just hanging on by a thread, trying to pump out the blood that it can. So ACEs and ARBs are going to be really great medications for heart failure because they decrease preload and afterload. So they ease the work on the heart. They continue to allow the kidneys to get blood flow. And that's going to be one of the end organ failures that is really painful for patients with hypertension and can happen with heart failure as well. And then ACEs are going to be the medications that cause cough. When your patient, doesn't seem like a big deal, but when your patient gets it, they get it. So go ahead and move them to an ARB. ARBs can cause angioedema, as well as ACEs, but angioedema is going to be more common in the African American population, and that's just when your lips and mouth, throat starts getting very swollen, and the patient should be educated that that can be a side effect, and they should go to the hospital. Also, ACEs and ARBs are contraindicated in pregnancy. Now, let's think about why that is. It will disrupt the blood flow to the fetus, and then it is a teratogen. So, then beta blockers are really well indicated in heart failure because they decrease the heart rate and the systolic filling time. So then they decrease the ejection fraction and increase the stroke volume. So metoprolol should be used in general for patients with asthma and COPD. That's because metoprolol is a selective beta blocker in that it will only block beta 1, which acts on the heart. And the propranolol, you can use, but it is not selective, so it may cause some bronchoconstriction because it acts on beta 1 and beta 2. And then Corag is another beta blocker, but you would not use Corag for COPD because it blocks beta 2. And then nitrates. Your patients with heart failure are going to have chest pain, and you're going to want to use a nitrate for that. It opens up the blood flow in the heart and allows the patient to, and they would use it when they're having chest pain, and it allows the chest pain to stop. Ionotropic agents like Digoxin, those are not really used so much anymore, but it enhances the heart's ability to pump, increases contractility, and it creates a hypokalemic state, like a somewhat hypokalemic state. But you want to watch out for this drug because it can cause yellow halos in your vision, also bradycardia and prolonged PR. Prolonged PR can lead to a heart block, so you would not use it in a patient with heart block. Diuretics can be used. They reduce the sodium reabsorption in the nephron. And then the side effects are hyponatremia, gout, and then ototoxicity. So if you were to push the Lasix in too quickly, it could cause blindness. You wouldn't use it in pregnancy. And it does not actually decrease the mortality of the patient, but it does help with those symptoms, like the peripheral edema will clear that right up, or pulmonary edema will also be able to help with that. So the first line drug in heart failure is going to be the loop diuretics. And it'll just optimize the patient's volume status. Other medications, bumesuride, temocide, those are both loop diuretics. And then the ACE inhibitors, they increase the patient's chance of survival, so you want them on one of these. Although, you watch out for the side effect of cough and angioedema. An ARB will be a little bit more expensive than ACE, so if the patient has a cough, just move them right to that ARB. And then the aldosterone antagonists are not really used too much. That's the spironolactone, and it's a type of diuretic that is a little bit less potent. And then beta blockers. So that's going to increase the overall survival of the patient and help them with their ejection fraction. So you definitely want to have it on the patient on one of those. Corag, in particular, if the patient does not have COPD, is the first choice. You really need to give it because it decreases the peripheral resistance of beta 1 and mortality, and it increases the lung volume, which is the beta 2 action, but you wouldn't want to use it in somebody who has COPD, of course. The ionotropic agents, they're really not indicated. You kind of would want them to go to a pulmonologist for those to be given. And then last but not least, what are the most common causes of exacerbation of heart failure? So go ahead and put a comment down here if you want to add one on. I will just name a few of them right now. Non-compliance, infection, salt intake, fluid intake, alcohol use, anemia, arrhythmias, uncontrolled hypertension, and then renal dysfunction. So go ahead and write what you think is the most common one in the comment section below. Thanks so much.